Hello, everyone. My name is Mukta, and I'm a faculty member here at Azim Premji University. Welcome to the panel discussion organized by us at Azim Premji University on the occasion of this year's World Mental Health Day. My name is Mukta, and my colleague Arima will be moderating today's panel discussion. The theme for today's panel discussion is Changing Landscape of Mental Health. As we began brainstorming the ideas on deciding what should be the theme for today's panel discussion, we realized that the mental health landscape today is a mix of hopes and challenges. There is mental well-being, which is there in the standard definition of health, which is a state of physical, mental, and social well-being. The question remains whether health discussions really address mental well-being, or are we still, caught up in the binaries of mental health versus mental illness, and also the binaries of physical health versus mental health. While there is a gradual push for deinstitutionalization in addressing mental health, it has taken several years for us to really imagine what that means. What do we mean by deinstitutionalization? In 2007, we saw a crucial milestone when India ratified CRPD, which is Convention for the Rights of People with Disabilities. It's still recent, in 2017, that we had Mental Health Care Act with a rights-based approach. So on one hand, we do see some space for mental health related discussions opening up because we have mental health policy. We see a global push for community-based mental health services. We also see gradual focus on social determinants of mental health. But at the same time, we do see a lot of challenges at several fronts as inequalities in mental health outcomes persist. The issues related to accessibility and affordability of mental health care are there. And a lot needs to be done in terms of engaging communities in mental health related discourse. We also realize that COVID-19 pandemic has really gave a lot of visibility, unfortunately so, to also some of the opportunities to work in the domain of mental health. Because at the same time, it was highlighting the kinds of challenges and inequalities that we see in the space of mental health. But it also helped us realize that mental health is not just a concern of only a few, but it matters to each one of us. All of this brainstorming has led to the theme that we have for today's panel discussion, which is Changing Landscape of Mental Health. And in this context, we feel that it is actually important to ask some of the pertinent questions. If the mental health landscape is changing, is it changing for better? Are we heading in the right direction? Where are we in terms of addressing stigma faced by people with psychosocial disabilities? Several community-based experiments are being tried out in different parts of India. Some of them have task-sharing approach. Some of them have peer support groups. Some also have art-based therapies. What do we learn from these experiments? And that's why it is time to pause, to deliberate some of these questions. So in today's panel discussion, we aim to engage with these pertinent questions with the speakers we have with us today. So I now request my colleague Arima to introduce today's speakers to all of us. Thank you.
Thanks, Mukta. It's an absolute privilege and actually a joy to be able to introduce our panelists today, and really look forward to their kind of engaging with these pertinent questions that Mukta has really set it out in the context setting. Let me begin with what is important actually, and what interests us is that about the three panelists, all of them are deeply committed to mental health, and all of them have kind of straddled these different worlds of teaching, research, practice in different ways, but they all kind of enter into mental health from different vantage points. So let me begin with the first panelist, Anand Bhan, who is a mentor and principal investigator at Sangat Bhopal Hub. And he has a training in medicine and followed by a postgraduate training in bioethics. Anyone who works in the field of public health is actually familiar with his contributions to bioethics. Particularly the work on mental health has really focused on questions of access, questions of equity, questions of ethics, questions of marginalization, and he continues to also kind of spend a lot of time in building capacity building of health professionals as well. He has been a member of several committees, including the World Health Organization COVID-19 Ethics and Governance Working Group. Of course, he has been a long-time national ASA mentoring group as well. This is just to name a very few. And he also, as all of us kind of know very well, really a practitioner and a researcher, somebody who is really committed to advocacy and also an academic. So welcome, Anand. We look forward to hearing your thoughts. Our second panelist is our Padmavati. It gives me a bit of a different kind of joy because she's a psychiatrist by training, and she's one of those few psychiatrists that I have had the opportunity to interact, who talks about and appreciates the role of personal caregivers, their role in particularly treatment and healing. We have had fascinating discussion on narratives in mental health, narratives as evidence. So that's something which is very fascinating. She is the director currently at Schizophrenia Research Foundation, has been there for a long time, more than 28 years, and she has been quite a committed researcher apart from the practice in a number of areas, including community mental health programs and telepsychiatry projects. She's interested in the cultural aspects of mental health and also keen interest in psychosocial rehabilitation. Welcome, Padma, to this panel. Our third panelist is Jasmine Kala, who interestingly comes from another kind of a background, training in social work and sociology with a gender perspective. Currently, a program director and a research fellow at the Center for Mental Health Law and Policy. Her, lot of kind of interesting work that she has done on evidence-based implementation research at scale for mental health and human rights in low-resource settings. She is currently co-leading the scale-up evaluation and implementation of a community mental health program called Atmiyata, which is focusing on how to enable access to mental health and social care. And previously, she has worked on peer support, recovery, and health systems reforms through the World Health Organization's Quality Rights Scale-up in Gujarat. And she continues to provide capacity building support to other countries as well to implement the quality rights framework. So warm welcome, Jasmine. So thank you all the panelists for really taking out your time and agreeing to engage with this quite an important and a timely conversation, I would say. So we'll begin with Anand. Anand, if you could just give us a broad sense of where we are in terms of, has there been a significant change in the way that we are trying to now understand and approach mental health? And has the paradigm of whether it's illness or health, has it really changed? Has it made an impact? What else that would you say in terms of equity, access, or any other thing that you would really like to highlight on this? So over to you, Anand.
Sure, thank you. Absolute pleasure to be here today among friends. Thank you, Arima, and also great to be on the panel with Dr. Padmavati and Jasmine, friends for a long time and co-travelers in the mental health field. I thought, given that we have a mixed audience, I just start off with a reminder that when health was defined by the World Health Organization, the definition speaks to complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. Now, this is something, of course, all of us who are in the field of health start off as understanding one way of approaching health. And it's also important to remember that last year was 45 years since the landmark Alma Ata Declaration of 1978, which identified primary healthcare as being key to the attainment of the goal for health for all. And sort of the larger picture issue around comprehensive primary healthcare. Now, if you look at mental health, just as a reminder, almost 1 in 4 individuals globally suffer from mental or a substance use disorder sometime in their lifetime. And almost 20% of the global burden of disease is constituted by mental and substance use disorders, which could be higher than many other forms of health conditions, which often get more attention, such as cancer or cardiovascular ailments. And I think most worryingly, there is a huge treatment gap, right? And that treatment gap means that most individuals who need help are not able to access help in a quality manner or a timely manner, and that treatment gap can be as high as 70 to 90% for some mental health conditions, which is a very worrying statistics, right? Now, when you combine that with the fact that there is a scanty mental health workforce, whether you're talking about psychiatrists, psychologists, psychiatric social workers, who are again very much concentrated in urban parts of India, you have a condition where it's even more severe as a crisis almost in rural and semi-urban parts of the country, right? So that is where we've been for many years, and that I don't think has changed significantly, even though the number of medical schools and health professional training institutions has been increasing. The other challenge, I think, has been services, right? Are there services available, especially in the vicinity of where people live? So, of course, for a long time, mental health was considered a very specialist paradigm provision of care model, and so was only available, let's say, in a medical college, in a tertiary institution, maybe if you were lucky in a district hospital with the district mental health program, if it was active. With some recent reforms over the last decade or so, as comprehensive primary health care again became a focus, you now have the CPHC model, the comprehensive primary health care model under Ayushman Bharat, where mental health and neurological conditions are one of the 12 sets of services or packages which are supposed to be available in primary health centers, the upgraded health and wellness centers. The question being, are MNS services, mental and neurological services, really available in terms of screening, in terms of diagnosis, in terms of linkage to care and follow-up? So that is something which is also an empirical question, I think, because this change has been relatively more recent. There needs to be more implementation research, more health systems research to understand that what kind of a change have we seen, and if has that actually helped address the treatment gap that we talk about. Now, one of the things which Arima and Mukta spoke about in the initial comments was the fact that given that we have a scarcity of professionals, we might need to look at alternative models of making healthcare accessible closer to communities. And one way to approach that is to look at psychosocial interventions, which don't need, for example, a clinician to be there. These are interventions which are evidence-based and can be effective for many health conditions, for anxiety, for depression, for PTSD, for forms of autism, etc. And in some cases might even have better long-term outcomes, for example, for depression with lower relapse rates. In some cases, they could also be a very good add-on for drug-based interventions or pharmacotherapy, especially for conditions such as psychosis and addictions. So the evidence is there towards that. But then how do you bring these psychosocial interventions closer to communities? And that's where I think this whole approach of task sharing becomes relevant, because if you have health professionals, community members, community health workers who can be trained and supported to deliver psychosocial interventions, that's one way of approaching access and ensuring services are available. Now, it's important to remember this is not very new as a concept, right? Task sharing has been also leveraged successfully in other fields like maternal, neonatal, and child health. So the whole Gadchiroli model, which Dr. Abhay Bang, Dr. Rani Bang, and colleagues developed in Search, which was then scaled up across the country, also involved actually working with community health workers to make maternal, neonatal, and child health available widely. Now, the other plus, in a way, because there are downsides as well, which has happened over the last many years, has been the advent of digital technologies, right? Now you have more and more digital tools available. You have wider smartphone based access in communities. And could this technology or access to technology be leveraged to provide more services, again, by training more health professionals, by having more services delivered through mechanisms such as telepsychiatry, telemental health, etc. And also with low data tariffs, is that something that we need to think about more actively in countries like ours, is something which is important for us to remember. Now, in our own work in Madhya Pradesh, we've been trying to evaluate and see how feasible, how acceptable are digital approaches to training and supervision, and what can we learn from that to try to look at what can be scaled up for health systems. Because while there is an initial input cost to digital technologies, over the longer term, you might find them to be cost effective, again, if they are effective in the claim of being able to provide quality training and supportive supervision when delivery of care is happening. And that, I think, is something we need to see more of, to ensure that while we are also looking at digital technologies, we are also constantly evaluating to see if they really fit the bill in terms of the context that we work in. The other important part is rehabilitation, and that is where somehow I don't see the same kind of perhaps focus that we see with treatment and first level care and rehabilitation. Also, I think there are some very good models in the civil society sector of rehabilitation, of also deinstitutionalization, of providing supportive care in community settings, which we need to look at. And that hopefully is another area where we will see more and more of work happening, because in the absence of that, I think we will see a lot of individuals who we are failing by not actually ensuring that they are rehabilitated and supported to be reintegrated back to communities. Uh, One important aspect is the stigma aspect, and I know Dr. Padmavati will speak to that much more in detail, but I do want to hint towards the fact that stigma is one reason why there is also a reluctance to access services. So even if you make services available, if people don't go ahead and if they're not willing to be screened, for example, for conditions like depression, you will never be able to perhaps pick that up, because the symptoms might not be very different from physical ailments, like, if you have anemia, or if you have generalized weakness because of some other conditions, your symptoms might mimic conditions such as depression. And that's where I think making spaces available and making conversations around mental health more accessible, so that individuals feel comfortable talking about mental health and their own struggles with mental health, becomes important. And this, of course, needs to be targeted also. For example, with young people, online spaces might work better. And some of our colleagues in Sangat have been using websites, chatbots, creating spaces where young people can speak to each other in a confidential manner and be supported by each other. And so that's another place where technology could play a role. We also need to do more outreach. By way of example, I have been involved with a grant which India Bioscience gave up, which is a science outreach grant, where we've been working with the Center for Brain and Mind at NIMHANS and conducting a series of events focused on different aspects of mental health. So we did an event at the India Science Festival in Pune. We have done events at NIMHANS, at the University College of Medical Sciences in Delhi. Last month, we had an event in Bhopal at the National Museum of Mankind. And the idea being, let's go out into public spaces and have conversations around mental health on a variety of topics, exploring bipolar conditions, public understanding around mental health, neurodivergence, workplace and mental health. And in the near future, we'll be organizing one in Mumbai on what constitutes recovery from serious mental health conditions. That, I think, is important, because once we start having more conversations and normalization, hopefully, of lexicon of just the public understanding of mental health, that might help address some of the stigma issues. Now, if we want to redefine mental health care, because which is part of what we want to discuss today, then we need to focus on, in a way, 4 questions, right? One is, what kind of mental health care are we talking about? Where do we want to deliver this kind of mental health care? Who would be delivering it? And the fourth being, how would they deliver it, right? So if we just simplify it to these, then that would be one way of approaching. And of course, for that, we need to look beyond often a very biomedical approach to mental illness. And that mental illness is not mental health, right? Mental illness is one component of mental health. So if we start to look beyond clinical interventions, we talk about how are we going to go to communities, to individuals who need help, rather than waiting for them to come to tertiary care institutions where services might be, where there is a strong element of social justice and equity brought in, where we talk about how do we bring down coercion in the way mental health care is practiced, promote recovery, then we will be speaking to that. And that's where I think evidence-based care has to be at the center, but it also needs to deal with these larger issues around hierarchies of biomedicine, around cultural approaches to mental health care, the fact that there is now a lot of money being thrown in the field of mental health as well, and that I think is something to think about. So some issues which I think need more attention, and maybe we can discuss more of those in the panel, is one is specific communities or subsections of the population and their mental health needs. Women and mental health being a very good example. If you just look at the perinatal mental health issue, you will realize that 1 in 5 pregnant women are likely to have some experience of depression, right? And this is just something which is not picked up. even with India's strong focus on maternal and child health services and programs, we just don't have a good program which does screening for depression during pregnancy. And that means many of these women are missed out on. Workplace mental health, which is the focus of the World Mental Health Day, which is tomorrow, as the theme for this year. We've seen recent incidents, the incident in Pune, the unfortunate incident in Kolkata. Many of the issues around toxicity, around workplace pressure, stress, were sort of alluded to in all of these conversations. But are we really speaking about that more openly and trying to address that? The fact that a large section of our population has non-communicable disease and multiple comorbidities, and if you look at evidence, again, it's very likely that if they have multiple comorbidities, they might also be having mental health and well-being related issues. But are we really screening for that and providing care for that? And are we able to pick up this nuance? And also when we are working with delivery professionals, people who deliver services such as physicians, nurses, paramedical staff, or in our case with ashas, they are also under a lot of stress. In fact, when we started working with ashas to deliver psychosocial care for depression, they said it's great that you're working with us to try to deliver care for communities, but what about us? No one seems to care about our mental health and well-being needs. And that sparked off some team thinking at our end, and we now then designed a innovative project called Anand, which focuses on working with ashas. COVID was something that we talked about in the introduction. So now with post-COVID-19 conditions being a specific area where there is a lot of discussion happening and patient-led initiatives, the interface with mental health is also an important part. One other important element, I think, which is extremely important, is this whole issue around lived experience and the voices of those who are experiencing mental health conditions. Because these have been classically often excluded, generally in health, I would say, and health and medicine, but especially so in mental health. So if you're talking about patients, service users, some of who frame themselves as survivors of the mental health industry, but also importantly caregivers, are their perspectives really center staged in the way we talk about it, about mental health? And perhaps in some way we've seen conversations about this happen with celebrity sharing of struggles with mental health, some unfortunate deaths by suicide, which have brought forth some of these conversations around lived experiences. So if you look at the Lancet Psychiatry focus for this month, the October issue, you'd see that one important feature question that they ask is, who should be in control of a decision about an individual's own body and mind? And this being especially fraught when it involves mental illness. So this whole issue of soft coercion, strong coercion, healthcare professionals taking on the responsibility of taking decision-making powers, and sometimes there being a lack of shared decision-making is something to think of. We in India have a very progressive legislation, the Mental Health Care Act, which is one of probably India's most rights-focused legislations. And of course, it came through after a long series of consultations, etc. But as we often see in many jurisdictions, including India, the devil is in the detail, which is the fact that there is a policy implementation. You have a great law, you have policies linked with that, but in most states, the mechanisms under the act have really not been implemented, right? So there is then a question around intent by governments and also what they are practicing, right? In contrast, what we saw was for at least a year, there was a strong focus on mental health in the budget, which was the launch of the Telemanas program, right? The platform which makes telemental health now available. So now the platform has grown, it's got countrywide coverage. But again, what I would suggest we need is good quality implementation science to understand what is working within programs like this and what needs more improvement and attention, which is crucial for any good program, is to have sort of this kind of ongoing monitoring, evaluation, and remedial action. Partly what is challenging is also alarmist approaches, so sensitive portrayal. I think all three of us on the panel would perhaps agree to this, is that sometimes insensitive, inflammatory narratives around mental health are a major problem, and that contributes to also the reluctance to access services. And with the growth of social media and social media related toxicity and violence, that is also something that we need to think about, because quite honestly, even physicians or nurses or psychologists or psychiatrists sometimes themselves are not very comfortable speaking about their own mental health, and that is something to worry about. The print carried a story last year in July, where the title of which was "Everyone's a Therapist in India." You have influencers, you have dentists, you have homeopaths. It's the new epidemic, right now. What that article was sort of alluding to is the fact that there are a lot of people who are making claims, right? You have so many apps which have come through post-COVID, which claim to be doing mental health or delivering mental health. But is there an evidence behind those claims, or could potentially these delivery platforms and individuals causing more risk or harm? And that is deeply worrisome as well. Also important to remember some major determinants, social determinants of mental health. So I did a Google search. I thought, let me play around with that. And Google gave me an AI overview of what are the social determinants of mental health. Very interestingly, education, housing, income, violence, interpersonal and collective, migration, discrimination, social inclusion, and social isolation, and also um, other factors such as gender identity and sexual orientation, which can impact it. And the US Surgeon General, not very long ago, actually came out with a report saying there is an epidemic of loneliness and isolation which is creeping, right? And that perhaps is also impacting many of our communities and subsects of population, such as young people, where again in India we have evidence that the level of mental health conditions, suicide rates are fairly high. So that is something for us to think about. But then what does the evidence indicate in terms of what can we do beyond the classical mental health response? So for example, exercise, evidence indicates, is a very effective treatment, with walking, jogging, yoga, strength training, whatever you can do, being a good response. But the larger question from a public health perspective would be, do we have spaces which allow, for example, women to go out and exercise? Do we have spaces in our urban sprawls which will allow someone to go to a garden and in healthy air and be able to take a walk every day? So we can prescribe all that we want, but are these even feasible in some of our conditions, in some of our settings? Towards the end, I would like to maybe point out to some of the work that we've been trying to sort of engage with, and this is around mental health and marginalization, right? So trying to understand the experiences of queer communities, trans communities, non-binary individuals, persons with disability. And repeatedly in conversations, what comes up is a major health need being mental health care. But not any kind of mental health care, mental health care which is affirmative, right? Which is focused on their needs, which understands their lived realities. But unfortunately, most providers are not trained to be affirmative providers. They don't learn it as a part of their training or their ongoing capacity building, and this pushes community members away and likely increases mental health related morbidity from them. We also have to recognize that sometimes we shy away from discussing some of these important determinants. For example, caste and other forms of discrimination, and what impact do these have on mental health? And allied issues, if you talk about tuberculosis as a national priority, of course, people who are undergoing chronic conditions such as TB are likely also going to have high rates of depression and mental health conditions. Leprosy, neglected tropical diseases, sickle cell disease, in some partner organizations working in Central India have talked about high rates of mental health morbidity in patients and families with sickle cell conditions. So again, all of these are important pointers for the kind of changing landscape of mental health that we speak to. And again, as I said earlier, the tech obsession, which is often now also in a way impacting mental health, there are several advantages. In fact, in some of our work, we've been using technologies such as AI and ML, but I also find a lot of fancy terminology being thrown out. Too many apps making too many claims, and perhaps not adequate focus on issues such as data privacy, ownership, protections, risk mitigation, etc. And that is something I think in the changing landscape we also need to talk about. So here are some thoughts. Maybe they were all disjointed, but hopefully they will help us in the conversation. Back to you, Arima.
Thanks, Anand. No, they were, we're not disjointed at all. I think what is important at the core of what you said, Anand, is in terms of trying to focus our attention to what mental health that we're talking about, where and who has to provide and how. And I think I would like to add whose mental health that we are talking about, because I think you drew attention to this, one kind of social group, but there are many that we could talk about. And I think another thing which is interesting is that, you seem to be kind of telling us that we have made inroads into mental health in different ways, but evidence is something which is important, and that is why you kept talking about, that implementation kind of research in figuring out, does this work? How does this work? Whether it's task sharing or technology or whatever, right? Something that I think we need to keep doing it to be able to understand that, okay, this would work here, how, etc. So great thoughts, Anand, and I'm sure the audience would have many questions to all our panelists. Do type your questions in the live chat box, and we'll definitely take them after the panelists actually share their thoughts. Mukta.
Thanks. Thank you so much, Anand. Uh, so you spoke about creating inclusive, non-judgmental, non-stigmatizing places, both physical spaces as well as social spaces. And you also spoke about how stigma often is a barrier why people do not seek mental, health-related treatment and care. I think this is a good thread to kind of go to the next speaker, who is R. Padmavati. She has done a lot of work on addressing stigma around, people who face stigma, who are suffering from severe mental health conditions. So I invite Padmavati to talk about, where are we in terms of addressing stigma faced by people with psychosocial disabilities. Over to you, Padmavati. Can we please focus on Padmavati, Shashwat? Uh, yeah, I can see her joining.
Yeah. Thank you. Thank you for, initiating this, or I would rather use the word continuing the conversation surrounding mental health. And because we've had a lot of conversations, especially over the past few years. And again, Anand has set the tone for this panel discussion in a beautiful way, giving us a nice overview of the situation. My remit here is, as a psychiatrist, as a researcher, what do I think about stigma? I would like to start with, is there stigma at all associated with mental health conditions? When I first started working in the field of stigma, there were one or two papers that I did see by people who were actually telling us that there is no stigma at all. You're just making it up. You're just saying things like that. So the answer to that question is really yes and no. Of course, more trending towards yes, because there is a lot of evidence, a lot of those scores of publications across the world which talk about stigma related to serious mental disorders. And having been in the field of mental health, serious mental disorders over the past 3 decades, I can certainly vouch for that, saying yes, stigma manifests in different ways. Some of the very crucial ways in which stigma manifests is in the language used, and I'm not going to be talking in a hierarchical manner. I'm not rank ordering them, but just as thoughts come to my head, uh, the language used, how does one address persons with serious mental disorders? There was a paper which I was one of the was privileged to be part of, a paper called Concept of Madness, which was authored, for the first author was Alex Cohen, who's done a lot of work on stigma. And we tried to understand how people in the community, look at mental health. How do they speak about mental health in different parts of the world, in three settings, it's a part of the Intrepid study in Trinidad and Tobago, in Nigeria, and in rural Chennai, rural parts of Chennai, outside the outskirts of Chennai. And we found that, there were numerous words by which people were using to refer to somebody with mental health problems. For example, the most common word in Tamil was paitiyam, right? Pagan, which means it's an equivalent of the word pagan. But we also found that it's often used even in a non-mental health context. So, what is the real difference between persons with mental illness and persons in the normal so-called social context of using these kind of words? Right? The context in which persons with mental illness were addressed in a particular way was rather to do with their lack of functioning, a poor functioning, not in the not in keeping with expectations of the community, was one of the things that was a glaring. This was a qualitative study, and therefore it was very data centered kind of a presentation. The other thing that we noticed about the language in which people used was, again, if you want to describe somebody who's poorly functioning, right? There are, words in Hindi, words in Tamil, words in English, which would talk about the person in a very derogatory tone. It was not just about the words used, it's also about the tone in which the person was addressed. Then, of course, we all know about family centric stigma, how a person with schizophrenia in a family is often sidelined. I remember the story of one individual who walked into SCARF at 4:30 in the evening. I was just getting ready to leave. At that time, he walked in and said, I want to ask you a few questions about this illness. My daughter is suffering from schizophrenia. So I said, okay, I gave him this usual thing about how he had to come in during the day, during OPD hours, and so on. But he was refusing to let me go. And I actually stayed back to listen to his story. He lived in a two-bedroom apartment in the heart of Chennai city. And believe it or not, his two so-called normal children had no clue that the eldest daughter in the family had schizophrenia. There was so much of secrecy around it. So they would take her to the doctor when the other two had left for work, and so on and so forth. So these are some of the, the lack of disclosure, lack of sharing of information is quite commonly seen amongst families. And of course, when you look at, again, when you look in the context of when you're talking about families, we're talking about marriage, about people with mental health problems. And in a very interesting study done at SCARF on women who are married and suffering from schizophrenia, we did see that many of these women were actually sent back home to their parental home because they were suffering from a mental health issue. Uh, just a moment. Camera. I'm sorry about that. Yeah. So basically, as I was telling you, there are a lot of issues centered around families where, again, the women who were sent back to their families were actually disowned by their own siblings, right? So it was the elderly parents who had to take care of the person with mental health problems. Okay. Now, there's a lot of evidence to talk about interpersonal relationships with family, especially amongst the younger generation. So we've had young people come to the OPD and say, look, I'm not talking about my psychosis to my boyfriend because my boyfriend will then leave me and go. This is something that I'm sure every mental health professional would have heard of, these stories like this, where, they don't want to disclose. They don't want to disclose to us. Just today in the OPD, I had a woman who's a doctor who's about 60, was talking to me about her 40-year-old son with a diagnosis of schizophrenia. And I must have seen that son once because I said I insisted on a personal examination before I could prescribe medications. And she's been coming to see us for quite some time. And every time she would come alone, there's some teleconsultation, telephone conversations with the son. And so treatment is happening. Now, over a period, so SCARF is a not for profit organization. So we are always constantly asking people to look for some kind of donation, some kind of corporate social, corporate support, and so on. So, in the same way, I told her one day that, look, why don't you, we don't charge a consultation fee. So, when she raised this issue of a consultation fee, I told her, okay, why don't you make a donation to SCARF? So after several months, she's come today and she said, look, I've got a check which I want to hand over to you. But unfortunately, because my husband's family doesn't know about my son's problem, my own family does not know about my son's problem, I can't ask anybody. And I don't want to tell my friends about it. So stigma comes from home. There are people at home who don't want to disclose this kind of a problem. So, I mean, we are still there. It's not that the stigma is like, I mean, it manifests in so many different ways that sometimes it's really hard to actually list it out and address each of them. Again, coming to the question of institutional stigma, there's a lot and lot and lot that one can talk about. But just to give you an example of how hospitals, general hospital, any community general hospital, how do they deal with persons with, say, for example, schizophrenia? So I have a bit of a horror story to tell you here. So I had this lady who was under treatment with me for schizophrenia, and she happened to be she attempted she jumped from the first floor of her apartment. So there was a broken bone, right? In the immediate action that the son took was he took her to a local private hospital. The woman was made to wait outside for a long time, and at that point in time, one attender in the hospital comes and tells the son, "Didn't you see the board outside? We do not treat persons with mental illness in this hospital." Right? There was no such board, but this woman was made to wait for 6 to 8 hours. Naturally, the son calls me up, and of course, we made arrangements in some other hospital, pulled some strings here, talked to friends, and the woman got treated. She became better. She became better both physically and mentally. But it was a real horrible situation. And, at that time, I was so angry that I decided to raise a noise out of it. I called up my friends in the press and said, "Look, you've got to report this," and so on. There were some interviews done. There was a small bit. We got, some space in the print media. And after that, total silence. Okay. When when I called my friend in the press back, I said, "Oh, it's no longer an important thing. My editor is saying no, this, that." So, what I'm trying to tell you is that people are not willing to even talk about it, whether it's in the print media or whether it is in, at that time, I did think, oh, maybe I should have got some private television channel to cover this whole thing. Maybe there would have been some visuals as well. But anyway, that opportunity was lost. There was another hospital which was even more a horror story, was when a person with schizophrenia was taken to a hospital with an abdominal pain. And you know what happened? The person with the duty doctor and the emergency room of that hospital actually doubled the dose of antipsychotics that the patient had. And the rest is history. The patient collapsed through the night. We do not know what happened to him because no investigation was done. So I can go on and on and on and on and on about how, for example, I mean, it's a very popular thing for example, in the United States, it's true in many parts of the world, where if there is a shooting incident, immediately they're watching out for whether the person has a diagnosis of schizophrenia and then blame everything on mental health problems. Even in the city of Chennai recently, we had in one of the small, within the city of Chennai, there was one man who was sitting in a bus stop waiting for a bus to come. He was not very untidy, but pretty disheveled, and he was seen to kick some. Normally when things are there on some Coke can or something, he was seen to kick it off. He was also noticed to be muttering to himself. Immediately, the people around thought that this man is a person with mental illness. He will become a danger, and he was beaten up there. He was beaten up there, and of course, it raised a lot of hue and cry. And eventually, the police stepped in and admitted him to the hospital. The patient died. That's another story. But then the point is, this should not have happened at all. Someone just kicking a empty Coke can, and someone is sitting there and muttering to himself. For all you know, he must have been talking, had a earplug on and maybe singing along some song. We don't know. But this is for the public response. Having said so much about, what all is wrong, right? I can't leave this scenario with talking about self stigma, right? Now, self stigma is another thing that can be a barrier, because there are times when people say, for example, there's another young lady today in the OPD. I had a heavy OPD today, so a lot of my references are coming from there. There was this young girl who said, she's about 31. Her parents want her to get married, and she kept saying that, look, I am going to talk about my mental illness. My first response was very good. Very good. I'm so happy that you are going to be disclosing information and so on. And so she comes and tells me after that, after I finish my, my gratitude to her and so on, she comes and tells me that, the reason why I'm going to declare, I know he won't get married to me if I declare my mental illness. I don't want to get married because I don't think I'm capable of running a family. Now, I thought to myself, now this is a kind of a manifestation of a self stigma, which I think we also need to be aware of. I mean, young woman, marriageable age, and wants to look for a future, wants families want her to get married. What do we advise these people? This is a question that cropped up in my mind today, and I reminded myself, yeah, this is something I must share with the audience today. Right? Now, having said so much about stigma, I would also like us to reflect upon situations where there is no stigma, right? You'll be surprised. I mean, you remember when I began my talk, I asked if there is stigma associated with mental illness, and my resounding answer was yes and no, right? Now, so where are the situations where there is no stigma? Of course, these are very rare, but I think we have to train ourselves to watch out for these situations as well. For example, a very supportive family. Right? You have a young woman who gets married gets married into a family who knows about the mental health problem, right? And of late I have seen an increase in these kind of occurrences where the families by marriage do come and talk to us about issues especially pertaining to pregnancies, childbirth, parenting a child, and so on and so forth. But then there are such issues that crop up in our practice that we do see. The other, I've done a lot of rural outreach work, and I find that in the rural populations, the support that persons with mental illness can get is sometimes very, very phenomenal. They are, the neighbors there, the neighborhood communities, the village heads, they're all out there to, of course, I cannot generalize this, but in many of the places which I have been to, I've noticed that it could either be giving them food, giving them some small money, or giving them work. This is something which we have noticed, and I'm sure these are situations where if you try and explore on stigma, it could be much less. Now, then this really moves us on to the next question of, has it changed over time? I've been in practice for 3 decades, as I had mentioned earlier, and so has the stigma changed? um Again, my answer would be mixed. It's not, I can't say a measure that yes, it has, stigma has reduced and so on. But we now find that a lot of people are seeking help directly without a referral from either a GP or any other consultant. They are coming to us directly, or other families can actually refer patients. So one of the questions we ask at intake history is, how did you get to know about SCARF? So they will say, oh, there was a patient who's taking treatment here, or my family referred, or I saw the board and I walked in directly. So these kind of occurrences have increased over time. We have a lot of young people who, we have an active telepsychiatry unit. So a lot of young people actually call us up and says, look, my parents don't know I'm seeking your help, but I think I'm stressed, I think I'm having a problem, and I would like to talk about it. This is something that we have definitely heard a lot. Just give me a minute. Yeah. So yeah, just one moment, I need to charge my laptop. Many apologies for the break. Yeah. So I realized that I got carried away with time. So yes, it has changed in a way. I mean, look, more and more peer support workers have come into play, and therefore that, I mean, I'm sure Jasmine will address that in her talk. So that again, I think, has helped reduce stigma. A lot of community engagement programs are looking into using people with lived experience in communicating about mental health. Use of arts and theater is again in a very big way an understanding, helping to reduce the stigma. What more can be done? I think it's very important for us to build evidence that our attempts at reducing stigma is really working. And I think we have a long way to go there, because monitoring and evaluation strategies for community engagement programs is still, I think, not much talked about sphere, but it is still there. Better use of social media is, I think, called for. Better conversations, multi-pronged conversations are really needed to help us communicate more about mental health and its issues. And I really like the term that Anand used on sensitive portrayal. I would definitely like to end my conversation here with reiterating the word that whenever we talk about mental health, there has to be a sensitivity in the portrayal of what we are saying. And I guess panels like this will definitely help to improve the conversations, improve the way we are talking about mental health. So thank you very much for this opportunity. And yeah, over to you, Mukta or Arima.
Thank you so much, Padmavati, for sharing such nuanced thoughts on how stigma gets manifested at different levels. One could be self-stigma, it could be family-centric stigma. Also, something I found interesting, which is linguistic expressions, also in the form of tone, not just the words that are being used. Institution, related stigma. Uh, I also found it nice to hear that we still find some hope in terms of how this landscape is changing in terms of addressing stigma, building more evidence, and having more sort of sensitive health communication around mental health. And a very important point, which brings us to the next speaker, which is bringing people with lived experiences to talk about, their experiences and bringing them in mental health discourse. So maybe this is a good time to also bring in Jasmine here, who will be talking about the peer support model in the space of mental health. Let's understand from her what that means and how to understand, how it can help in changing the landscape for better.
Thank you so much, Mukta. And thank you for the invite. Really appreciate. I agree with Padma. This is more to continue the conversation that hopefully will evolve over a period of time, and we'll need lesser of these conversations and more of action is where one is hoping to reach. So I'll probably just begin by framing where are we with the mental health gap, as we call it. And I think framing the problem is equally important, much like the panelists have said before, is just framing of the problem will determine what the solutions are. So what we have been saying is that there is a large mental health care gap. Typically, we've been looking at the treatment gap as the problem, which essentially means those who want to seek services, are those services available? And unfortunately, that's been seen as something which is a health sector problem or a specialized professional sort of a problem. So therefore, a lot of our solutions or the way the health systems is organized is to say, if there is a treatment gap, therefore we need more and more professionals to be pumped into the system. Now, if that were the case, just adding more professionals would have solved our problem. But even globally, we know that that's not the solution. Even if you do put in professionals or specialized professionals, by which I mean the psychiatrists, psychologists, therapists, and so on, that is not going to actually reduce this treatment gap or the large mental health care gap. So where is the gap really? Is not just looking at what the professionals can bring into this space, but also looking at what are the psychosocial gaps that we can see. By its very nature, one says psycho and social, then we're looking at social determinants of mental health, which also need to be addressed to close this large mental health care gap. Briefly touching, I think Padma's touched upon this, it's also looking at what happens with health and mental health together, because they're often seen as siloed interventions rather than seeing them as more intersectoral or intersectional sort of issues. So that's more about the large mental health care gap. And what one is seeing is that even if you do make the professional services available, people might actively choose not to seek those services. And that might be because they're not considered more acceptable to the people who want to seek those services. It's not catering to their needs. It's probably often we found that it's not of good quality, it is not affordable, it's based in settings which are extremely hard to get to. And what we have seen throughout our work in communities and in health systems is while stigma is a determinant, but the consequences of opening up about your mental health condition also leads to very severe forms of discrimination. And there are lots of structural barriers in who gets to seek services, where do they get to seek these services, and what sort of response do they receive based on their social position and understanding of the context. So, what I did want to just then frame it to say is that often we're looking at mental health as a health sector problem or the problem of professionals. And I think it's probably time that we unpacked this to say that we need more than just a professional form of support. That's the growing evidence now that we do need to also look at other forms of care and services. Maybe and because the topic is about changing the landscape, I think what I just wanted to highlight is that that needs to be the primary focus of reframing the problem. And that does require a paradigm shift in which we are approaching the mental health problem, as to say. So our present health systems is primarily focused on more curative sort of intervention. We're pumping in the very, very limited money to more tertiary kind of services, which are more specialized services, which are often not based in our communities. So what we do see is that there is this large gap between a lack of, the preventive, promotive mental health care, which actually communities really need. We need supportive communities of care rather than just looking at a health system's response, which often is always going to be inadequate to cater to this large need that we have. So if that's the scope of the problem, if that's the scope of the this large gap that one is seeing, what do we really do? Where do we begin? One would assume that ideally you should begin by speaking to communities who are facing the mental health concerns due to various psychosocial, economic, political the systems which are impacting their mental health. So how do we co-design these interventions? How do we reach out to our communities to ensure that the services that they need are being provided by us, by the mental health sector and beyond? The other thing, I suppose, what we need to do is, since Mukta has already mentioned the CRPD, is how do we build interventions that are backed um, by a rights-based approach and by a recovery-focused approach. Now, what do we really mean by these rights-based approaches? That, I mean, for those who are interested, the CRPD is an important document to look at, which has informed our local laws and policies. But I think Anant has also pointed to this, that while the laws and policies exist, what changes on the ground is equally important. So how do we implement, how do we practice some of these great principles of rights to practice for everyday use by people like you and me? So how do we make these approaches more, while it is rights-based and recovery-based, but how do we make it more accessible to all sorts of community members, and especially people at the margins? So when we're looking at a recovery-based approach, we often then say, I mean, I suppose probably just take a moment to think about, I'm sure there's something that you have had to recover from in your own life and your own journeys. And if you think back on what helped you recover and what didn't help you recover, you'll probably see that things that probably helped you were maybe healthcare was one of the things that helped you. Maybe it actually was a negative experience. But beyond healthcare and beyond healthcare response, something that helped you recover goes beyond some of these systems. Maybe it was the support that you got for your employment, support that you got for continuing your education or making accommodations for your education, or perhaps linking you to other kinds of positive support that you needed to recover from that difficult experience that you might have gone through. Now, the similar case happens for people with mental health conditions. While healthcare is part of your journey for recovery, it's not the only piece of the puzzle. So, if we are looking at what pieces of the puzzle really then need to be looked at, is very broadly that mental health is therefore inherently an intersectoral issue. By intersectoral, we mean that it's not just the healthcare system response that needs to come to your rescue, but actually all other systems that can accommodate your needs can make you feel included on an equal basis with others. The other thing that is inherently part of this conversation is intersectionality. So one can't look at mental health as just a problem. It's not like we carry only one identity. We have multiple identities, and all of those identities need to figure in your recovery journey. So, framing that context, peer support is one of the models in which there's now growing amount of evidence. However, I feel like there is a lot more to be done. But before I get into that, peer support more broadly is about somebody who shares some level of lived experience with you, somebody who feels familiar to you, somebody who has some who can probably come into your life to give you some amount of hope and reassurance, link you perhaps to services that might help you achieve your own goals. And all of this support is provided on the basis that your will and preference gets prioritized. And that's really where broadly peer support fits. Is every form of friendship a peer support? Perhaps not. So there is some technicality to people being supported to provide that peer support, which is the unique element of how it needs to get done. However, all of us at some point in time have reached out to somebody we feel comfortable with, and it often happens to be somebody that you have some shared experience with. So peer support inherently is trying to say that for me in my recovery journey, and it's called a recovery journey because there is no linearity, there is a lot of turns and ups and downs that you will go through. So it's somebody to support you through that process of your getting better or staying in a particular situation which is probably also not getting better. But the central idea is that there is some form of support that can be made available, and this can be also it can be created by design if it doesn't exist more naturally in our environment. So however, to do peer support, one does need to recognize that this is a valid intervention in itself. We do have hierarchies of who is important to provide support. So I feel like maybe that the fundamental shift that we need is to actually recognize that beyond healthcare services, there are other evidence-based interventions that can be applied by non-specialized mental health professionals as well. And peer support is also one of the models to provide an evidence-based support, which doesn't mean that you are providing peer support in, like waiting for a professional to come in at some point in time, but it's in itself, it's a valid form of support. Typically, what we've seen with the peer support models is it is coming from more high-income country context. So while in principle there is a lot of agreement for peer support, there is lesser and lesser evidence to say how should one do it and where can one do it and who is an ideal peer who's positioned well to provide this kind of support. And some of these interventions that have been done are, for example, one that we had done was based in a health systems intervention itself. So it was based at a hospital-based setting where people with more severe forms of mental health conditions provided support to others by either filling up, say, a recovery plan or organizing some support group meetings. The other form of setting that we have tried is more community-centric kind of support, which is enabling the communities to address their own mental health and social care. This intervention is called Atmiyata. There are some papers around it, so happy to share more resources as needed. But essentially, the idea being that how do we enable our communities to get enough tools and resources which are backed by evidence to ensure that other members of the community can access that support, and it is delivered by somebody who's from the community. There are elements of peer support. There might also be some sharing of personal experiences about reflection on what are their goals and how do you ensure that people can reach their goals in a way that is respecting their preferences in life. How do we ensure that services can be provided without pulling people out of their community-centric approaches and putting them in more unnatural institutional care, where healing and recovery then inherently becomes more challenging. In terms of some amount of evidence, which I think is probably not enough, but what it is showing is that peer support has certain added advantages which a biomedical or traditionally clinical models cannot provide. So there are a lot of indicators which might then lead to um, more positive outcomes for people, which could include them feeling more socially included, could ensure that they feel like they have a voice and they can participate in their own communities. This is slowly getting traction. The model of peer support is getting traction. However, I think one is kind of facing some challenges around the how to's, and I feel the evidence generation needs to come in more from our context. And I think each of our communities in a country like India are so diverse that there is a lot of opportunity to try out different models to ensure that they're getting evaluated, to ensure that we found the right kind of peers, who benefits from these interventions is equally important, and therefore who gets to provide that kind of support is also equally important. So maybe just to end, I feel like the peer support model by itself, while it borrows from a recovery-based approach, the question really is, can it be done by not looking at rights? So, I mean, are rights and recovery not then interlinked? If you do have to feel like you are probably on your, if you want to participate in your community setting on an equal basis with others, one really can't look at getting better from a mental health condition without addressing all of these other psychosocial, political, economic indicators as well. Um, so yeah, I suppose maybe I will just pause there and leave some space for more comments and questions. So
Thanks, Jasmine. That was very insightful on trying to understand the peer support model. Very tempted to ask a quick question is that, see, while peer support model holds a lot of promise in terms of democratizing, in that sense, mental health, right? So I'm just wondering, what is the role of caregivers in that sense? Personal caregivers, also family caregivers, in this, in enabling the peer support model. But more importantly, I'm a little curious to know is that in a community setting, based on your kind of observations so far, um, do you think that peer support model also has helped in destigmatizing mental health? I mean, ideally it should be, but has that been the case, from your work setting? Right. I mean, in some contexts, the community context can be so complex. So familiarity in that sense may be inhibiting rather than enabling, knowing, right? So I'm just wondering, what are some of the initial kind of insights that come from the work that you people are doing?
yeah, fair point. I think the idea of the peer in itself with the shared experience, it can be applied to various kinds of settings. So I feel like if you're looking at caregivers as a group and as a community, then someone from that community providing support to their members is completely workable. I think the whole value of peer support models and it allows for so much flexibility, and their basic amount of tenets and values and principles, if you can apply it to different settings, whether it's education or health systems or groups which are more marginalized or caregivers or people with lived experience by themselves, there is a lot of opportunity to adapt the interventions based on applying certain forms of principles and a certain amount of evidence lens as well to ensure that it can get practiced. Your second question of whether peer support like interventions can reduce stigma or change attitude, it's a fair one. I don't think I have a lot of evidence from our community-based model to show that, because it's one of those challenging issues. To change attitude, I feel like it's a longer process and a longer journey. You can try and input a lot of the elements. So for example, we use the medium of films to talk about what are the determinants of mental health rather than clinically looking at, say, depression and anxiety. We try and make it more lived reality context for our communities. So we take stories from the rural communities, talk about mental health, but in a more social deterministic way, which could be domestic violence, unemployment, conflict, alcohol use. Now, this is also part of reframing the narrative around mental health. What we have seen is, broadly, I think all of us tend to think that people don't talk about mental health, but our experience has been slightly different. We've realized that people are talking about mental health. They do speak it. I think Padma has brought in the point about language, and that's extremely crucial. So, me talking about my mental health problems as stressors, tensions, that's an equally valid narrative. It's for us to recognize it. It's for us to improve our skills and upskill ourselves to respond to what people are saying. So often we are shutting down conversations because you actually don't know what to say. So, you can have lots of campaigns to say it's okay to talk, but actually one should really say it's okay to also respond. And we do need a response rather than just talking. And I mean, listening is a big part of it, and even listening is not happening. So I feel like it's a lifelong sort of a project, and we are hoping to see some changes over time for sure.
Absolutely, absolutely.
Thank you so much, Jasmine. A lot of work is being done to address stigma at the community level, as you also spoke about what Atmiyata is trying to do. But I would like to take this question on addressing stigma, especially in the health systems, and I would like to ask this to Padma if she can also come on screen right now. Uh, she shared this troubling incident where the person with psychosocial disability sort of faced stigma and was silenced when tried to seek treatment in a hospital. Uh, my question is, how do we also build health systems? What can we do to build health systems which are, creating spaces which are non-judgmental, which are non-stigmatizing? Any thoughts on that?
Yeah. Yes. Several thoughts actually. One of the things that I have been doing, I mean, I'm also part of a community general hospital, right? So one of the things that I'm trying to do there is not hesitate to, talk. For example, if they, I mean, I do get invited for, lecturing students, to talking to public, in public domain. There, many of the my hospital has what is called as a program where they have monthly meetings for general population, and I do get invited, and I never hesitate to talk there. The other thing that I am doing is I keep telling, you know, if there is a call from the emergency room department, I never miss that call, because I think young people, young doctors there have to be, you know, I spend that few extra minutes telling them what really, how do they communicate to somebody who has been brought in following an overdose of medication, and, so on. Like, for example, there was a doctor who said, oh, she must have said there's a love failure and therefore she's taken an overdose. I'm sure she'll be all right. So I said, you cannot dismiss it like that. There is a psychosocial problem that is there. There is a cultural, socio-cultural problem there. You should know how to be able to address. It has been a long journey in trying to get people to think about mental health in a better way, but I think I'm getting there, right? So one of the things that I do believe is that, even educating the medical fraternity not educating them in terms of what are the different kinds of psychiatric illnesses and so on. I think educating them to, listen to people with mental health problems, so-called mental health problems, is, I think, a very important issue. Fortunately, there is a small change in the syllabus as far as the undergrad medical education is happening. So hopefully, the next breed of doctors, as we can call them, we can definitely, may show a little bit more improvement in the way they are communicating to people. I think it's all about a very consistent education. And when I mean education, not a classroom education, but more observational education. So I do let internal medicine students actually listen to me when I'm doing a history taking. Right? History taking, okay, you don't normally follow the textbook that is there, because over a period of time, you know how to talk. So I do let them sit and observe when we are doing, and I encourage them to actually talk about this. And of course, we also, wherever there's an opportunity to speak, everyone at SCARF is given the, is encouraged to, reflect upon mental health. And I think that's one way of telling people that. So it could be a stall in a mela, or it could be a college which is calling you for a thing. We go and talk, because I think it's important we talk without using jargon. The only condition we make is don't use jargon, don't use words like schizophrenia, bipolar except in the passing, but maybe make it more understandable to the listener. I think that can go a long way, especially in a hospital setting. Nurses are another group which I think require a lot of address. And I do not lose an opportunity to talk to nurses.
Yes. Thanks, Padma. So I think we have quite a few questions from the audience. So we'll take this up. And so could I request Anant also to come to the spotlight as well? So one of the questions is around community mental health. So I think so all of you are invested in this space. So anyone of you can take it up. It says that most of the community-based mental health programs are providing services in a fragmented way, little bit with a not inadequately taking into account a life cycle approach and disregarding social determinants of health. How can this be factored in the community-based mental health interventions is one question that is being asked. Any one of you can take. Yeah, Jasmine, maybe you can do it, or Anand. Yeah.
Go ahead, Anand. Go ahead.
Okay. Let me take a crack, and maybe then Jasmine, you can come in. So I think it's a fair question. Maybe there is a hidden criticism in it. But to be fair, I think a lot of models that we have of community mental health, especially by civil society organizations, like the ones all three of us are affiliated with, we work on narrow budgets, often with projects and with deliverables, right? And that's where I think what we need to see as the role of civil society experiments in mental health is more perhaps doing innovations, demonstrating evidence, and then providing that evidence for public services to incorporate. We should not be seen as agencies which are here to replace the government or public services. That is the role of the government. That is what we have to push our governments and our health systems to do. So if there has to be a truly comprehensive and inclusive community-based mental health program, that has to come from the state. We can only provide mechanisms, examples to them. That having been said, again, I think all of us need to be introspective and self-critical about the programs that we do. And I think that is an ongoing conversation. So all of our organizations also need to be more inclusive, more cognizant of the determinants that we spoke about, the intersectionality approach which Jasmine was speaking to, the kind of self-stigma and stigmatizing approaches which are also still pervasive, and the dominance of mental health professionals in a lot of our organizations. So that I think is ongoing change, and certainly our organizations are not immune to some of those problems. But again, I would urge us to think about what should we be expecting as citizens or as residents of this country in terms of what the government should be providing, and how can this large body of evidence which has been created actually be implemented on the ground through services, which is our right as individuals who live in this country.
Right. Thanks, Anand. Another question, perhaps I could direct it to Padma, is that, trauma responses or coping mechanisms like hyper independence resist people to validate that they need support or assistance from others. How do we then break the barrier?
Interesting question. Very interesting question, really. See, the thing is, it's all about understanding one's own distress, right? And acknowledging the fact that, there is a distress and we cannot live in a silo. You might be very hyper independent, and I know of a number of young women who live alone, who don't want to do it. They don't want marriage, they don't want family, they don't want anything. But I mean, I'm referring to the fact that it's women because I see it more amongst women. I'm sure there are a lot of men around too. With this is not about a gender debate, but the point I'm trying to raise here is that they do believe that you know there can be no problem with them, right? And I think we're all human beings. At some point there will be a cold, cough, fever, etc. Same way there could be some low mood phases, some difficult, almost traumatizing kind of frames of mind. And it's always healthy to acknowledge that. And like Jasmine said, it's okay to talk, right? And that's something people need to understand. And very often I find that young people are, I mean, they're so hyper independent that they'll come to you only in a state of crisis, which could have easily been avoided, right? So I would urge, like, us to consider the fact that look at us, look at ourselves as to what is happening today, right? We could be in a great mood, we could be in a state of distress. If there is distress, we should really be acknowledging that, right? And if I may take the liberty of responding to the earlier question about community based organization, I would just like to share a bit of information about what we are doing. Like Anand rightly said, all three of us have been involved in some kind of community based program. But at some point we and like any funded kind of programs, we were also thinking, this program has come to an end, it was such a lovely program and so on. But then we asked ourselves, we can't be here forever, right? We have to like learn to let go at some point. So what we did was we just had a few grassroots level workers who were a kind of go between the village and the district mental health program. So there was only a referral system, but so it was not a medical treatment. We encouraged them to go to the DMHP for whether it is treatment, whether it is disability, certification, whether it is trying to secure welfare benefits from the government and so on. So a kind of a handing over process to the government has happened. And again, this is a very small exercise. The evidence is supporting the fact that yes, it is possible to hand it over to the government.
That's very useful to hear. There's another question which is asking, and any one of you, maybe Anand, have we really truly integrated mental health care in the healthcare system? Is a question that's being asked. We almost know the answer, but I think you should still elaborate.
You want to hear it from us?
Yeah, I will.
Anand, I'll hand it over to you.
Sure, sure. I mean, I think all of us could probably answer in different ways. My answer actually is like all things in life, this is like a shade of gray. So I don't think there is a yes or no answer here. There are services and there are professionals offering good services, both in the public sector and private sector and the not-for-profit sector. I think, services are available, but they are clearly inadequate, and there is a lot to be done. And that's what I think some of the conversation today has also focused on. And I don't think that there is a dearth of evidence. There is evidence that we could still address the gaps if only we were open to innovations, to thinking about the delivery of mental health in a way which is accessible to communities, something which they would accept and which perhaps is going to be sustainable. And that is certainly not a model which is a model only delivered through tertiary care, right? So if we want truly primary healthcare integration of mental health, that would need to have mental health democratically available and available at all levels, and not just relegated to specialist care. If we get that done, then I think we might have a much better um, availability and perhaps better indicators as well. So when if we meet in a few years' time, again, we might have more encouraging statistics to share with all of you. But I would be very keen on hearing from Dr. Padmavati and Jasmine as well, their thoughts on this.
Yeah. So I'll go on now and see. I was just reading through the comments in the chat, and one of the things that they said is most hospitals have visiting psychiatrists and not, a department of psychiatry as such. Yes, this is true, but I think it is because of various reasons. Because in a private hospital, people are looking at income generation, and they also take into account what are the analytics when you have a department of psychiatry, when you have full-time psychiatrists. Are you generating enough money like what a department of surgery would do, or what department of OBGYN do? So one of the reasons why most hospitals don't recognize the need for a department of psychiatry. On the other hand, even psychiatrists, if you go, I mean, say for example, in Tamil Nadu, perhaps we have the highest number of private psychiatrists in the country. And in this kind of setup, what happens is that you have a psychiatrist who's going from at least 3 or 4 hospitals, and for every hospital they are a visiting psychiatrist. So one hospital will have about 3 or 4 visiting psychiatrists, right? So it's a very difficult I mean, it really requires an attitudinal change, both from the hospital management side, especially in the private sector. I think most government hospitals do have their departments of psychiatry and have a full team of mental health professionals. There's another challenge to this whole story. See, if you looking at a department of psychiatry in a general hospital, whether public or private, it becomes medicalization of the entire story. And if you remember, Jasmine had talked about a multi-sectoral approach for mental health care, and somewhere along the line we tend to lose out on that multi-sectoral approach if you are making it a kind of a medical setting alone, and it becomes more pharmacotherapy oriented rather than a multi-pronged kind of approach.
Right. So perhaps, Jasmine, I could come
I
back
think,
to you, and you might like to kind of address
yeah.
the question on the community mental health program and whether it actually addresses social determinants of health, because this is linked to what Padma also just mentioned, right? And that question, and if you could also combine that question, another one on the peer supporters, they think that peer supporters sometimes, for their own peace, start avoiding persons with, other persons with mental health conditions, how to manage this situation, perhaps in different contexts, somebody's kind of observation. Yeah, if you could take these two questions.
Sure, thanks, Arma. I think, yeah, everything's been said. The integration of mental health within the healthcare, I feel like the question should be, what is mental health care? I think that is something we need to unpack. And we're still, if you look at just the professionals kind of infrastructure, then even that has not happened. But is that really the need? I think that's the big question, because there is now increasing evidence to say that that's not the only kind of services that one needs. And therefore, that opens up a lot more conversation around, I mean, where do peers then figure within these health system structures as well? So one of the interventions was through the quality rights, is where we'd, formally, I mean, Gujarat is the only state which actually formally employs people with lived experience as peer support volunteers who are present at these healthcare services. Now, even if you're not getting, and that opens up the conversation of what is mental health care then being provided, which goes beyond, I mean, yes, the clinician can help you with the clinical bits, but where do you go from there? Because it is a bit of a life altering event. So, where do I get now support? Where do I get services is equally important. And then that anyway breaks this binary of what is mental health and where are the other sectors in it. For me to feel well, I do need to then look at the education sector. I need to look at the employment sector. And we have to open up this conversation, I think, which is getting very siloed into mental health. I think fundamentally, if we can say this is intrinsically linked to other sectors, intrinsically linked to other kinds of services, services that we need to be providing, that I think opens up the conversation a lot more. And then it's like Anand said, it's then not a binary, it's not a yes or no, but actually just really examining what is it that we want. In terms of social determinants, I feel like that is a very crucial question and again speaks to silos. While in Atmeta, I think we always started off by saying that there's no point talking about like mental health support through counseling or through the referrals and sessions and so on, without even ensuring that people have basic amenities. So I think integrating things like, say, social entitlements within your interventions is such a minor start that it's probably not even a starter. But I think increasingly one is just finding these gaps between sectors who are not speaking to each other. And I feel like that's a huge opportunity for us to change when mental health is becoming a conversation. And I'm hoping that the conversation then doesn't remain with the mental health sector, and actually all of us working in the social space can recognize that mental health is touching upon, poverty and mental health is so intrinsically linked. So poverty reduction will lead to better mental health outcomes. So it's also about what is it that you frame problem and what is it that you're trying to measure. So our measurement points, unfortunately, are also becoming very clinical rather than also looking at other social outcomes that one could get. So yeah, maybe just wanted to come in there. For the peers, I think what the hidden message is what happens to peers' own mental health support. And that, of course, needs to be recognized. So most peer support interventions will look at your own mental health support that needs that you will have, which will change over a period of time. But I think the idea of calling yourself a peer supporter the whole idea is that you will address this problem rather than ignore it. So yeah, I think if the question is hinting at what about me, then yes, that's an equally valid question.
Thanks, Jasmine. I think there is another interesting question. Based on what Anand shared, is that you mentioned about consent in receiving mental health care. How is working with children and adolescents possible, keeping their narrative at the center, keeping also the consent in mind? Anand, would you like to take this up?
Yeah, I mean, it's an important point, but it's not unusual in the sense that that is true of any other form of healthcare, right? Consent or assent models have to be there for adolescents, for children, and let's not assume that there is a lack of capacity automatically just because if someone is struggling with a mental health issue. In fact, I think mental health professionals are well qualified to evaluate if that is indeed the case, and then you might have a representative, a guardian, etc., who can provide consent. But certainly, engagement of the young person concerned is extremely important. And again, evidence indicates that a lot of mental health morbidity has early onset, and the sooner we intervene, the better it is. But somehow, often we shy away from doing that, and the later, hence, a mental health issue is identified that can lead to further struggles. So yeah, consent I think has to be central for sure, but let's not assume that just because the child or the young adolescent might have a potential mental health issue that they might not be able to provide it or engage with the consent conversations. For legal purposes, of course, you might have to go with someone who is a guardian or a parent or similar, because that's how consent operates.
Right. So we have almost kind of reached, 1.5 hours. We didn't even realize that. We would really like to thank all of you. I think from bringing out different aspects, this whole questions on mental health, beginning with what do we mean by mental health? As Jasmine was saying, we have got to begin from there. Are we only talking about certain kind of care, and medical care alone? But having said that, treatment gap is something which is a very, very, glaringly kind of an important issue. We need to address it. How? And stigma continues, but also as, Padma, it was very nice to kind of hear a lot of these, the sense, real life experiences, in the sense how it unfolds, in different places, etc. It also kind of makes us realize where do we need to work on stigma, right? Because if it's at a home, it's at institutions, it's at different levels, right? But it's also interesting to see is that there are some hopes that we can look at in terms of, maybe better social connectedness that we are talking about in rural areas. In some rural areas, we also had gone to another, place in Tamil Nadu, and we saw that, oh no, because we kept asking about stigma, and they couldn't comprehend why are we asking about stigma, because they don't have stigma, right? So it is quite interesting in that sense, both for mental health as well as for sickle cell anemia that we were talking about. So I think there are hopes in that sense of many things have been tried out looking at peer support model. And because the kind of issue is so complex in that sense, because there is no one way to look at mental health, right? So I think figuring out how things have worked, what is that we learn, from each of these models, is something that is actually an exercise, continuing exercise, is for all of us. So thank you once again, and I think our thanks to our audience. We just also want to say that the audience has really appreciated the kinds of different perspectives that you really brought to this particular topic. So thank you, everyone. Yeah, so we could kind of close, and I'm sure close here for today's discussion, but conversation on mental health has to continue. Yeah.
Thank you so much.
Thank you.
Thank you, everyone. Take care.
Thank you.